Oh, wait, I have to zoom in. Start with introduction. So, Amy, go ahead and introduce yourself. You're Amy from PAC.
From PAC, I'm the program specialist for behavioral health and substance use disorder services. So I could finally make it again, so I'm glad I'm here. Thanks for the invite.
Glad you're here, Amy.
Thank you.
Veronica.
Hi, Veronica.
Introduce yourself.
Hi, my name is Veronica. I'm an intern at Lehigh Valley Health Network. I'm at the One City Center in Allentown currently. So I'm really interested in psychiatry and psychology. That's my major. So.
Great. Okay, I'm trying to, who else we got out there?
It's Naomi from the.
Oh, Naomi. Hey, Naomi, from Neighborhood Health Centers.
Yeah.
All right.
Hi, Naomi.
We've got a little crowd so far, hopefully some more stragglers coming in, but let's go ahead and introduce ourselves around the table here.
I can't be seen. Cindy? Hi, my name is, should I look somewhere? Yes.
Well, oh yeah, you can.
Sure, okay. Stay where you're at, thank you for you. My name is Cindy Bello, I'm a stroke and alcohol counselor. I'm the Hispanic program coordinator at Mars, and I also work with the counseling solution of Lehigh Valley as a prevention specialist at CASA.
Hi everyone, my name is Yamelisa Taveras. I am the project director of counseling solutions at Lehigh Valley and here as a drug and alcohol counselor.
Hello, my name is Chris Stewart. I'm a community nurse with the Neighborhood Health Centers of the Lehigh Valley.
Hi, I am Jasmine. I coordinate MAT at Neighborhood Health Centers. I'm a registered nurse.
And I'm Abby Letcher. I'm your primary care host for the Echo today, and I'm going to look to Jasmine just for a second to see how do I get rid of this notes thing. Mm-hmm. Oh, Kevin, you want to introduce yourself? Kevin, can you hear us? You're on mute, so we didn't, if you were talking, we didn't hear you. We're going to unmute you.
There you go.
Now,
hey,
Kevin, can you introduce? Go.
Yeah, I can hear you. Can you hear me now?
You can, yes.
Okay, perfect. Thank you. So this is Kevin McNeil. I'm a family doc. I practice out in Hamburg, work with the residents as well. Glad to be here.
Great. We're just having some bizarre problem with our slideshow as usual. Star, can I ask you while we're doing that, can you read our little thing for us? Thank you so much.
Absolutely. Hello, everyone, and welcome to today's Echo Clinic. Before getting started with introductions, which you've already done, we wanted to share a reminder to maintain confidentiality by not releasing any personal health information on individuals being discussed today. Please mute yourself when not speaking by clicking on the microphone icon in the bottom left corner of your Zoom screen. Audio participants, please dial *6 to mute and or to unmute. Prior to speaking during the clinic, please introduce yourself by saying your name and location. This allows those who are using audio to follow conversation as they cannot see who is speaking. Thank you.
Okay, so we went from not having the right kind of slideshow to not being connected to Zoom at all. Oh, there I am. Okay. And I'll just, if you're distracted by seeing the notes, then I feel sad about that, but let's see how we do. I don't know if that matters, but. Right, and my screen share is not coming up. I think it's just,
I started screen sharing. I think it's just being really
it's just really slow. Okay.
There we go.
All right. So for those of you who are new to us, welcome to the ECHO. Yeah, I'll get it. That part's fine.
Okay.
The way the ECHO works is that we're going to start by doing a didactic. We're following the curriculum that was established by the HRSA ECHO for opiate addiction treatment. And we're happy to host you from NHCLV. After we do our didactic presentation, which is interactive, so everybody gets a chance to participate, then we will discuss a case together. Okay. So today we're doing part 2 of the office-based management of opioid use disorders. Last session, Jillian Beecham talked to us some about how to get started and how to assess somebody in a primary care office for opiate use disorders for MAT. Today we're going to talk about some of the challenges that come up, but mainly we'll be talking about interpreting urine drug screens, because that's always interesting. So by the end of the session, you all should be experts at interpreting the urine drug screen results, understanding the limitations. We're going to review strategies to recognize a relapse and adapt treatment plans, and think about some tools to help identify and prevent diversion. Oh.
Try the arrow, see if that works.
And you guys can't see my slides because it's not going anywhere.
Try to zoom slideshow.
That's what we're in though, right?
That's not what they see?
They're seeing that, but aha, there we go.
There we go.
Yay. All right, no disclosures. Learning objectives. We just went over those. That's interesting. Okay, so we'll start by thinking about the urine drug screens. Most important thing for urine drug screens is to know what is your office, whether you're coming from a drug and alcohol treatment program, whether you're in a probation office, whether you're in a primary care office, ER, wherever you might be, to be familiar with what kinds of urine drug screenings are available in your setting. There's a wide variety of different kinds of testing. The most important thing to know is that there's point of care testing where you can do something right there in your office. Someone gives you a specimen and you have some results to look at, and then lab-based confirmatory testing. So they all sort of get called urine drug screens, but one of them, the point of care, really is just a screening test. It gives you yes, no's, like you can see on this one, the U screen. It gives you 2 lines for negative, 1 line for positive, and it's just a yes or a no, and it's not a very accurate yes or a no for many different kinds of tests. So know which test you're using. I'll say that at NHCLV, we've switched companies a couple of times, and they behave a little differently. So you want to get familiar with what they look like and how to read them, with the sort of quirks of your particular test, and know when you need to get more answer than what's here. I think particularly from our colleagues in corrections, that they often rely on a point of care test, and that's actually not medically sound. So if we need to push back, sometimes that's a good place to start. Did you send a confirmation test? So if you're using point of care urine drug screens, know your test, have a backup plan so that if something does come up in an unexpected way, either something positive that you didn't expect to see or something negative that you thought should be there, that you have a way of confirming that. because they're not super accurate, you don't want to base treatment decisions just on this point of care screening result, because you don't actually know what it means just by looking at that screen. It's really a conversation starter, right? It's always a good idea to sort of frame in your context, how are you using these urine drug screens, and what kind of conversation are you starting? So these last two bullets on this slide, ask patients what you will find, no need to catch somebody in a lie. This is not about tricking anybody or keeping anyone from tricking you. It's about encouraging open, honest conversations, sometimes really difficult conversations. So you want to be able to just have another point of information that can help open that conversation up. Any point when any of you have any questions or ideas, feel free to unmute and chime right in, okay? It's important to also look and see either you haven't advanced yet. And you're going to go back and forward again probably. It's important to know for the cup or the oral swab or whatever that you're using for your urine drug screen, what exactly is in there. Most commonly it'll have you'll see this one just has a few: barbiturates, amphetamines, methadone, methamphetamines, cocaine, and marijuana on that side of the cup anyway. Many of them have a lot more, but it's good to know what's what. So in your opiates, those are all your non-synthetic opioids. I don't know what it's doing there, but kicked me out. That's what it's doing. Yeah, I'm having some internet connectivity issues. So the opiates, so that'll give you heroin, morphine, metabolites, codeine, but it's not going to give you the synthetic opioids, no oxycodone, no fentanyl, no tramadol. So if you want those, you're going to have to ask for those separately. I think it's coming slowly. Okay. Those are usually, the opiates are usually pretty accurate, but you also need to know a little bit about how long is the half-life. So how long ago will it pick up any use? For most of those opiates, if it's been more than 3 or 4 days, you won't see anything in there, but it'll pick up for a few days at least. Cocaine, false positives are pretty unusual, but still refrain from feeling certain about exactly what's going on based on a screen for cocaine. The benzos cross-react a fair amount, but those are pretty popular these days, so at least it's a good conversation starter. Marijuana, for people who are frequent users, the marijuana stays in your urine for a long time, 28 days, sometimes longer. So keep that in mind, that one stays around longer, whereas other ones may disappear more quickly. The amphetamines and the barbiturates have a lot of false positive with over-the-counter drugs and other sorts of things. You may also be looking at prescribed medications versus illicit drugs, and you may not be able to tell the difference based on these. This presentation says that they don't recommend the alcohol screening. Certainly don't recommend it for detecting whether somebody has an alcohol use disorder. The metabolites don't stay around for longer than 12 to 24 hours, so you're not seeing something even from 2 days ago, but we've actually found that it is fairly useful for us because then I'm back bumped out. Does anybody else have a better connection?
In the meantime, if you turn the screen,
that's working.
Would it show the right way or would it show backwards? Because they can at least then see that.
Should show frontwards because the echo is showing frontwards.
Okay.
So let's do that. Yamalisa, the queen of the workaround.
And then just zoom in. There we go.
At least in the meantime. Is it legible?
Well, not really legible, is it?
Yeah, no. Yeah, they can, I think, and they can
That's-
always solve their
That's just
screen.
the
All right.
angle, that's the
Yeah.
angle of the screen.
This goes backwards of what you think. I think we'll just leave it at that. Okay. Never a dull moment. You guys can still hear me though, right? And do I have a mouse?
They're shaking their heads.
You're right. It's just that I don't have a mouse anymore.
Is it a touch?
Where's my
Spacebar?
cursor?
Space bar sometimes works too.
I just want to get rid of my Zoom. Okay, any questions, anybody out there so far about the point of care urine drug screen while I try and figure out what the heck?
Oh, it's going. It did. So try the arrows.
I don't have any,
It
I have
did it
nothing.
there though.
Hmm?
But your back screen is going, even though you're seeing Zoom. See how it changes possible scenarios?
Okay.
Fortunately, you can't see it though.
Oh.
Here, I'll just come way over here.
Plug it in the-
Okay.
Yeah, zooming in.
All right, so let's talk about a case. We've got a patient who's stable on buprenorphine for months and has the urine drug screen, which you can't read there, but the basic idea is that the buprenorphine comes up positive, oxycodone's negative, amphetamine negative. It shows you the cutoff level for detection there. Barbiturates, benzos, cocaine, marijuana, all, and methadone, all negative. Opiates positive, that's opiates, not the oxycodone. Phencyclidine, propoxetine, both negative. He reports that he's doing well on treatment and he has no concerns, but we got this urine drug screen. So the question is, what are some things that might be happening here? Let's hear from our Zoom participants out there. What could be going on? Anyone want to give it a try? Got a few scenarios.
Yeah, it could be using, in addition to the buprenorphine, might be taking some other pain medication that's not prescribed.
Uh-huh. They could have taken some other medication and still taken the bupe. Based on what you know about the buprenorphine, Kevin, what kind of effect is he gonna, if he's taking the buprenorphine and the prescribed medication, what's he gonna feel from his medication?
Well, he's not going to, he's not going to have this patient's not going to have the same effect as he had before taking the buprenorphine.
Right, yeah, so that'll be an interesting conversation, right?
Mm-hmm.
What's another scenario? Think of something else. So one is he's taking his buprenorphine, but he also took an opiate. Not Percocets, but maybe some morphine or codeine. What else?
Can you repeat which were the positives on the?
Opiates, so the non-synthetic opiates, morphine, codeine, heroin, those will show up there, but not oxycodone, which is your Percocet, and not tramadol or
Methadone,
or fentanyl. Mm-hmm. Other scenario? Amy, you get to participate if you want to too. Or Veronica, there's no wrong answer. You guys got some ideas in the room? What else might be happening?
Hi, this is Cindy. A relapse might be a possible relapse.
Could have relapsed, okay,
Mm-hmm.
right? What else is possible?
But diversion is definitely a possibility as well.
Uh-huh.
Because many do report, I'm doing well in treatment, I do everything I need to do, but a lot of times because they have stopped their, or, you know, reduced their use of the buprenorphine and started using other things, so they can actually feel it. But to them, they're doing great because they're not doing as much as before.
Yep. Okay, let's see. Now it didn't change. Oh my gosh.
I know, we don't know what we can see anymore.
And it's not moving now.
Oh, there it did. Possible scenarios.
Okay, so possible scenario, relapsed with an opioid, like an opiate, such as heroin. Prescribed opioids for a medical reason, that was Kevin's idea, not the oxycodone though. Or it has a false positive. That happens sometimes, right? So you see this one that says he's got opiates. Sometimes our emotions come up and you think, oh, here we go, right? But actually you don't know that yet.
Excuse me, Abby?
Yep.
Comment on that just a little bit further, because, you know, I've heard, you know, different presentations about that and had very different, and people have had, you know, very different commentaries about that, to the point of people just laughing about that, saying it's really not possible, the amount of poppy seed ingestion that you would have to take, and that it was really unlikely that there would be any false positive due to something that they ingested. But I've heard, just as you said today, that can actually happen. So could you expand on that a little bit?
I would say that I debated taking that out of this presentation and left it there. What I've also, you need to eat a lot of poppy seeds.
Right,
like a nice handful of poppy seeds. I left it there maybe to get your question, and also just to say, you know, people will come up with things, and when you're having that conversation, they're going to have a conversation. I think that you never actually know whether someone took several tablespoons of poppy seeds or not. And if they're going to claim that it's absolutely poppy seeds, you know, if we're having one of these conversations, a difficult conversation about urine drug screens that don't match the patient's report, I think it's just best to stay in the zone of, I don't have my confirmation as of yet, but it makes me want to open this conversation up for anything that you want to share. And if they say poppy seeds, it's not absolutely impossible, depending on what the cutoff screen is. It's also not particularly likely. Oh.
Okay. All right. Do you think we should make that part of the treatment agreement? No poppy seeds?
I think that it's worth, I think it is worth sharing with patients that if they're under supervision with probation or parole, that they don't want to do anything that could possibly mess things up. And if there's even a vague possibility that poppy seeds or some of the over-the-counter medicines can be confusing, that because we know that the corrections departments often don't have the most wonderful approach themselves, that you don't want to give them any room to raise questions that that you can't convince them that you have an answer for. So so I would suggest to people that while poppy seeds don't, 2 poppy seeds don't give you a positive, you don't want to mess around.
Perfect.
I don't know, does that make sense?
It does, thank you.
I'm Elisa. What we do, at least at Mars, when we complete an assessment, we provide them with a list of foods and over-the-counter medications that can potentially give a false positive, so they're aware from the door.
Exactly.
And they're, of course, the recommendation is sit, read, go through this list, because these could be things that could be in your home now.
Right.
So they are more aware. And when we get back, those, oh, but I didn't know, we can refer back to, you remember this list? Let's go through it. And a lot of times in orientation, it gets discussed as well, for at least for the Hispanic program. But many times in group, I have had those conversations with groups and tell them, remember that list that we gave you? Let's go through it. I've actually sat and gone through and then have them ask questions like, oh, but this is only blah, 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 you know, oh, I'm only putting, you know, flavor in my coffee. Well, that flavor in your coffee has alcohol. So that they do become more aware.
Yeah, I think that's great. Kevin or Veronica, would you be interested in us posting Yamalisa's list of possible interactions on the ECHO site on the NHCLV or sending it out by email?
That'd be great.
Yeah, sure.
Okay, great.
This is Amy.
This is Cindy. I can give you a different scenario about a false positive. And this happened recently. We had a couple of clients testing positive for K2, and that's not their drug of choice. But it was hard for us to say yes, no. We have more than one. I believe the fourth one that tested positive, this was in a lapse of 2 days. He was almost crying. And it's very common for those who are dependent to cannabis to use K2 because it's X, Y, and Z. So what I did, I took a point of care and I submitted my own specimen. I'm like, let's see. And it just happened that there was a batch that it was providing false positives. So that can be also.
So there are actually
it can have the margin of error as well with the cup.
Yeah, and hence always sending the
I was positive for
confirmation.
K2.
Yeah, and you're not.
And I'm not.
Okay, you're pretty sure about that. Okay.
100%.
Yeah,
But
yeah.
that can happen as well.
Great. Yeah, and we've had situations in the inpatient floors when people have positives on their urine drug screen that they do in the ER at the point of care. Their whole treatment plan on admission gets directed by that screen, and it turns out not to be true. So it's an interesting process, right, Kevin, of how do you develop a relationship and some trust to really begin to understand, you know, give someone the benefit of the doubt and understand that that making too much room also isn't particularly helpful, that they want some, you know, people need in our relationships to have some accountability put around them. You just want that to be non-punitive and supportive of them being able to reach their recovery goals. Amy, you were going to say something.
I was that in my past experience, I worked with a few patients who would actually brew poppies to make a tea so that they would get the high from opiates. And I know that's, again, like the rare cases where you're taking a handful of poppies, like we'll never know. But that is something that people would share that they would do.
Thanks, Amy. That's a new one for my backpack.
And it was like, I don't want to say, like, people thought it was like a high class thing because they could do it like at work. And I mean, the stories I would hear were crazy, but they thought it was more socially acceptable, which is very interesting.
Because you're just drinking some tea. Yeah. And, you know, and over the millennia, humans have gone to great lengths to find mood-altering substances.
Naomi raised her hand.
Naomi, you got something to add?
Yeah, can you hear me, Abby?
Yes.
Okay. Something that I find interesting through patients is individuals who are not like smoking K2 or marijuana, but they have traces of it in their, you know, in their urines, that they're around individuals with secondhand smoke, that they're consistently in confined rooms or something like that. So they're not really taking part in it, but they're around other individuals. And they're getting traces in their urine. So that's something else that kind of complicates things as well. And letting those individuals know that those individuals that you're around are, you know, not helping you in a situation when it comes to your urines, if it's, you know, through law enforcement or whatever the case is. So.
Right. So Naomi, in your role as a certified recovery specialist, that opens up a whole nother set of conversations about triggers and risk and all of that, right?
Absolutely. absolutely.
Yeah.
It's something
right. So
that
how useful are.
How do I actually just come right out and let individuals know, like those individuals that you're surrounding yourself with is not a healthy situation. If you're, in a probation parole situation where you need to be, have urine screens and they're using those, that they can affect you. I've had individuals come in, crying, why is it positive? And it's something that we as individuals don't realize. Just like nicotine, it's secondhand smoke. So letting them know, again, people, places, and things are highly important. It's just on a mental level, or physical, but it's also on a physical level now too, because now you're inhaling someone else's, situation. So,
yeah,
having a conversation and making sure they understand that their surroundings are just so much more important as well as what they're doing.
Exactly. Thank you.
You're welcome.
Okay. So the chances are, though, that when we find the opiates in the urine and we get a confirmation that this is a sign of a relapse, right? So in our office-based practices, we may not have as much experience as you do in your drug and alcohol, or as Naomi from her certified recovery specialist, of how are we addressing relapse. I'll say also in the psychiatry universe, this is a new learning curve in the LVHN psychiatry as well. What do we do to address relapse? And I think this is an area where stigma can play a very damaging role. I think we know that substance use disorders are chronic relapsing diseases. We expect some relapse. We expect that they're going to vary in severity and in frequency, and part of our goal is to see them coming less frequently and less severely, and that may still be a sign of progress. Every relapse is a difficult and dangerous opportunity to learn about your addiction and your recovery process. So our stance from a harm reduction point of view at NHCLV is that we are not punishing people for relapses. We're not trying to catch people in a lie for relapse. We're trying to identify signs of a relapse as early as possible so that we can bring the support around somebody that they need. So with that, we don't fire people for a positive urine, particularly, as you know from the previous slides, definitely not from a urine cup, because you don't actually have accurate information yet. But even if they do have a positive confirmation and we discover that there is a relapse, this doesn't mean that the buprenorphine isn't working. It doesn't mean that that they don't actually take their recovery seriously. It means they relapsed. Any comments on that one from anybody? And so what we do is we intensify the treatment plan. So we can, in our office-based primary care practice, have more frequent visits, do more urine drug screens, put around more psychosocial supports. We can look at what are some barriers for them, what are some of the triggers. The luxury we have at NHCLV is a great team with people like Naomi on it, and you've met some of our other team members too. We also have really great partners out there. It's key to have good partners, so we've got our Mars crew here that we can communicate with each other and say, oh, we're worried about this, and make a plan together to intensify their treatment. And sometimes we need to make a judgment that the buprenorphine actually isn't the right answer for this person at this time, and refer them to a more intensive level of treatment. So looking at methadone or inpatient. It's ideal if we can be clear about that amongst ourselves, but when do we do that? And at the same time, those are individualized decisions. So anything anybody wants to add about relapse?
Abby, I would like your opinion on, as we're moving forward, we'll get MAT in the primary care offices in that hub and spoke model as the spoke. So in providing this care, when there's a certain percentage of people who will, of course, relapse, and then the idea would be, as we've envisioned it, that they would go to a higher level of care. Let's say, let's say Jillian's clinic in Allentown, or the LVHN pyramid clinic. What if? So I'm seeing a patient in my office, and we have that conversation. I make that suggestion, and they refuse to go. How do you think I should? How do you think I should move forward then? What do you think? How do you think I should respond? What are my options?
That's a great question. Let me put that out to the other folks who are on Zoom. Do you have any thoughts about what do you do when you think it's that there's a relapse and they might need a higher level of care, and the patient says no?
Naomi has her hand.
Naomi has a hand up?
Been up there.
Or maybe she still has her hand up.
Yeah, she hasn't taken it down yet.
What are your thoughts on that? You don't have to have a big answer, but what do you think about somebody's relapsed and not ready to accept a higher level of care? What's your approach?
So this is Amy again, and I have a lot of thoughts about this.
Yes, it's the big question, isn't it?
Yeah, and I mean, first of all, I think just because someone relapses doesn't mean they necessarily need a higher level of care, that there are other things that can be put into place instead of just saying, okay, you have to go to detox. Like, it just depends on the severity of the relapse. And two, I think if it's one of those situations where it's an absolutely, like, you need to go, I mean, just trying to really have that therapeutic session with the client, but then, according to, like, the ASAM criteria, if they don't necessarily, like, it's what they want to do too, like, it's what level of care they accept. So maybe having stipulations placed. Okay, you can stay in IOP if you go to a meeting every day, or if you do this, or if you do that, and just trying to, like, meet them where they're at without putting them at too much of a risk, if any of that made sense.
Sure. Yeah.
I think a lot of that makes sense, Amy. We've struggled with a lot of the same things. I'm going to turn it over to Mars because they've been the pioneers at accepting people's whatever they accept for their level of care and trying to work with a harm reduction approach that way. That was probably, Kevin, one of the hardest things for us to grapple with at NHCLV. Melissa was there for some of that with us. And I think Amy's right on that not all relapses are alike. And there are things that we can do to intensify our treatment plan in primary care to kind of wrap things around them more without deciding that they can no longer have a buprenorphine prescription. One of our luxuries in primary care is that this person is still our patient, whether we're providing MAT or not. So I like to start from that point of view and say, I'm here to help you be well. And this is a setback for you. So how do we want to move forward together? And oftentimes, there's a real temptation, I think, especially as primary care offices are getting started, to have rules set in place that will help you, guide you through ambiguous situations. But often, they can get you for some of it, and then there's 10% of those cases, or maybe more, that just aren't going to fit those criteria. So actually, the notes for this slide, I think, talk about how in Boston or around Massachusetts, a lot of places started out with, a 3 strikes and you're out kind of a rule, that you get 3 relapses before you have to go someplace. But that doesn't make any sense either, based on what Amy was saying. Some people, 1 relapse is enough to say, wow, we really got to talk about methadone or inpatient. And some people, they're making progress, they're doing better, they're kind of moving towards something. So maybe they need more time with the CRS. Maybe they need a coordinated plan with Mars, and they're going to bump them up to IOP. And maybe there's a different time that's going to work for them. Maybe meetings are really great for them. So I think it's a great time for some motivational interviewing to figure out what are that person's goal at that moment in time. And that whenever we have a setting where people feel like we care about them and build some trust, that they might be able to think about what an actual goal is. What do you guys think? You guys are the pros at this.
So there's definitely many parts to it, but two in particular will be whether they're refusing, and that I can speak on this. It will be refusing a level of care recommended at time of assessment. And then Cindy, for sure can discuss it when it happens while already in treatment. So as far as when somebody comes in because they're being referred by the PO or by primary care, mental health, whomever is referring them to have an assessment completed for their use of drugs or alcohol, whatever may be happening, they can come in to us, complete their assessment, be assessed at, a 3.7 withdrawal management level of care, which more likely than not is that they're actively using and need to have their body stabilized before they can step down to a different level of care. If they were to refuse that level, our job at that point in time is, of course, to have a further discussion about what's going on in that environment, why are they refusing that level of care. If they're they have the choice to accept a lower level. However, comes the licensing and liability. So for us, we would need to have them sign a refusal stating, I am not or I'm unable to accept this level of care. However, I am willing to accept this level of care. We encourage them to accept something as much as possible, but many refuse down to just OP, and they're like, I will only do individual once a week. We'll take it. Whatever, whatever you're willing to do. However, then comes in a treatment contract that can go into play right from the door, letting them know, okay, so we are willing to accept you at this level of care because of the situations that you've expressed, childcare, work, whatever may be happening that you are completely unable to enter. So it could be a referral for medically assisted treatment for them to get into seeing a care provider that can get them on MAT, attending meetings more often, getting referred to a CRS or an ICM or an ACT team, and having 30 days. And within these 30 days, we're going to see you at least, these many times per week. Provide, you're going to give UDSs. We're going to check on you. So it's going to be very intensive, even though you're not accepting the intensive level of care. It's pretty intense. As much as possible to surround you with as much support as we can, because you've accepted something, and we're going to work with you where you're at and provide that. And then they go from that just assessment. And we also give them a brief training on Narcan, actually provide them with Narcan. We are able to do that because that's one of the big things that we have, that yes, you came in because somebody made you come in, but you still came in. In order for you to remain safe, here's Narcan, here's, have this discussion with your family, and here are all the referral sources. We make appointments right from there. You're accepting MAT? No problem. Hey, Carmelo, Gina, can you get them an appointment and get them in? And then they immediately get scheduled with Cindy within a day or two to be seen a second time within that same week, and then her person.
This is Cindy. So that's a very good question, and the importance of integrated systems and integrated treatment, it's because of that particular question. So if Dr. McNeil has a client, they give a positive at his office, I believe that there's two components. There's the lethality and the ethical component, and the legality as well. So a client who is an opiate, has a SUD and is particularly opiate, that's a 911, because this client can OD at any moment. So the first part would be have a written document in where a level of care was offered to the client and he refused that. Because ethically, if this client OD and insurance company, anyone wants to review his record, what did you do? Well, it was a positive, and this was my plan of action. He refused it. If the client is positive and he's open to engage in treatment, or is currently engaged in treatment, those record releases need to be in place prior. So this is prevention. So if you relapse, this is the plan of action. I'm going to contact the person who referred you or who you're supposed to be going, and we're going to identify what's the next step. Mm-hmm. I wrote also that when it comes to group, let's say I have a client and I receive a call from Carmelo, and this person tested positive. So clinically, what we do is we call the client in and we try. It's individualized, so we have to see where they at, what happened. But if they admitted a relapse, especially for an opiate, we immediately offer a higher level of care, and it's just detox. We need to remove you from your environment, try to stabilize you, then you can come back. Second component is that person is removed from group often if they're actively using, not to trigger the one in group. Mm-hmm. So it's mainly individualized, but when it comes to the legality of it, it has to be a written document stating this was done and he refused it. So and if the client decide not to engage in treatment, then we completely change his plan for a harm reduction plan. Mm-hmm. All right, how are we going to keep you alive? And that would be the other part of treatment.
Yeah, so there's no easy answer, Kevin, except that we want to surround this person with people who can have real and in-depth conversations. I think we as a primary care can have some of that conversation, and we have some relationship that's kind of special because it goes on beyond a treatment period. But we want to have our partners involved in that conversation too. I think one of the big assets for this sort of situation is certified recovery specialists. There aren't enough of them in the Lehigh Valley, and I don't know what the access is in Hamburg, but there aren't enough of them in general. So Amy, I'm just putting that one in your ear. How do we advocate for more CRS availability? Because most of the time people will accept some CRS involvement because it's not threatening. It doesn't feel like we're forcing things on people who aren't ready. But Naomi can attest, having someone who can see you clearly and call your stuff for what it is can be really helpful at a critical time. And I think
I'm sorry, I didn't mean to cut you off. I totally agree though. I totally agree when as being someone in recovery, it's you take it more with a grain of salt from someone who's been kind of in your shoes. It might not be the same situation, but the outline is still the same. So for me, I understand where they're at. I might not have been in that particular shoe, but I get where they're at if it's in their mental standpoint, their thought process, why they've done it. So I'll call you out on it. And being called out from somebody who can kind of walk in your shoes or have walked in your shoes is easier than hearing it from someone who hasn't. Because your first line of defense is to be defensive to somebody who has not been in your shoes, as we all know in a situation. So that's something that I do with my patients is if I'm seeing it and it looks like what's going on, I will ask you. I will say, okay, so where can we go from here? What can we do? And I totally agree with Abby. There's not enough CRSs out there to support these individuals who do need the support, as well as the ones who are so not ready to not to have the reach out of a CRS, because this population, to me, is like we kind of look at ourselves as the stigma, the biases, unfortunately. So it's one of those it's kind of twofold, when you're ready, you're ready. When you're not, you're not. So again, I totally agree with Abby.
Yeah. And I'll say that one key that we like to teach our primary care teams is in regards to stigma. There's no need for us to shame anyone. That's not a therapeutic move. And our patients have probably heaped enough shame on themselves already. Relapse is people will feel a lot of shame, and nobody has ever been able to punish somebody out of addiction. So that's not our job. All right, so back to the urine drug screen patient mismatch. Your patient says one thing, the urine drug screen data suggests a different picture. Consider confirmatory testing. So it's not just the quantitative levels. The labs, NHCLV uses Quest labs. The LVHN lab does this as well. They'll show you quantitative levels, so you get a sense of where they're at. You have to be careful because people metabolize things at different rates, so a particular number doesn't mean anything. It's how it compares elsewhere. But they'll also show you metabolites, so you can see patterns that suggest which drugs might have been used. Again, we're not trying to judge people when we're having this conversation, so no accusations or comments on the person themselves, but you're talking about the urine. And I found that this is particularly helpful. Let me show you what the urine says here. And we do a lot of teaching at NHCLV to say, well, you know, we're looking at these metabolites. This is what it would look like if you're actively using. This is what it looks like when you are or aren't using your buprenorphine. We'll get to that one in a minute. But the more information people know, just like that list of what can cause some false positives, also what are we looking at, can help people sometimes open up and tell you something that they thought maybe they might keep hidden when they started the visit. And then here at the bottom, if we get down to it, Kevin, that the office-based MAT treatment, with the partnerships that we have, with the behavioral health contracts and all the other pieces that might be in play, if that's not working, then having a nice policy that you can back yourself up with to say, this is about patient safety. This is about your safety, not about me judging you as a failure, which is what everybody's thinking in their own head. This is about your safety, and for your safety, you no longer, we're going to not prescribe that. You are still my patient. You can come here. We can talk about your knee pain. I could do your pap smear or whatever, but I need you to go to this next level of care for something else. When they totally refuse, then you have your plan B, the harm reduction, right? But that might mean that I stop the buprenorphine. We don't very often, but we have, and it's been important to know that that's one of your choices. So back to that case, the first step is your urine showed opioids. Is there anything that I need to know about, right? Send the confirmation, and if they do deny a relapse, this one I actually had rearranged a little bit, but it looks like it didn't stick when we did all of our back and forths. That you're always going to be checking the PDMP to get that piece of information too. We are always asking the lab to confirm the results for anything that isn't exactly as we expected it. But start asking a little bit about recent triggers. Are there anniversaries of traumatic events? Are there people in your environment? Is there something else, like at work? We have a lot of folks who work in the warehouses or work hard labor jobs. There's a lot of people who are using on the job. Is that something that's happening? So just get a little, a moment for people to talk about what's stressful for them. And then we do have this option of increasing the frequency and the support right from the primary care office, reaching out to our team as well. I would say that we find that sometimes when we intensify the treatment with the visit frequency, people who are trying to get well may not love it, but they'll do it, and people who are not trying to get well will vote with their feet. That's another way. I need you to come in twice this week, right? All right, another case. So patient struggling since engaging in treatment. Intermittent relapses with heroin and benzos, smokes marijuana daily. She's at risk of losing custody of your child. So she's struggling with anxiety and insomnia, and today she comes into your office sedated and guarded and denies any recent drug use. Her urine drug screen result shows buprenorphine, but is otherwise negative. So you guys out there on the call, what are some scenarios that come to mind for you?
So I don't know how often this would occur, and so I'd ask for you to talk more about that. But is there what about false negatives for the urine drug screen point of care test? Is that a possibility in this setting?
Could be. Though if she's actually sedated, then we're thinking about pretty recent use, and it ought to come up positive. So the negatives are the sort of borderline if you're below the detection level, and some of these cups have pretty high detection levels, so they might show more false negatives, but a false negative is definitely a thought. Other thoughts out there?
It would be, substances that aren't detected by the urine drug screen point of care testing.
Yep. Such as?
But did you say earlier that we're just that we're not checking the synthetics?
Yeah, this one is saying that buprenorphine otherwise negative. Usually fentanyl is not on the cup. Opioids are, or oxycodone usually often is, but fentanyl isn't. This is a guiding answer.
Yeah, so that would be that's what I would think it would be.
Right.
You have concerns for fentanyl or something, or another synthetic.
But it's not showing the marijuana either.
Oh, it's not showing the marijuana. What do you think about that?
I'm thinking, well, where's the marijuana?
She's providing someone else's specimen.
So that could be somebody else's urine, right? Or really watered down urine, something like that.
So it's a sprinkled,
Sprinkle a little bupe in there.
Yeah, sprinkle a little bupe in there if you're not checking for metabolites instead of just the presence of, and rest is water. So where's the marijuana?
Yeah, and our urine drug screens that we're using at NHCLV have a little bit of the biometric stuff, so showing a creatinine so you can see how much urine is in the urine, right? That can be really helpful. Many of the cups don't have that either. It also has a temperature gauge, so if it's outside of the temperature parameters, too hot or too cold, that can be another sign of tap water. Yeah.
Email. This is Cindy. I worked with CYS for years as a drug and alcohol assessment counselor, and part of my job was to take weekly drug screens. And I have seen everything and anything you can imagine that will make clients have a negative drug screen, especially the drug screens that we provide our clients. They're not monitored. Anything can happen in that back.
Yeah, we don't monitor either.
If we look at relapse from a medical perspective and from the drug screen, we're taking a lot of the components that come with a relapse that is beyond a positive or a negative.
Yeah.
So with that case, we're mandated reported. So my first thought is going to be, is this child safe? So I will definitely have to, especially because she appears sedated. She probably used 2 minutes prior coming into the office. She bought it outside. It was given to her. Wait at the waiting area. So it's really the mandated reported part, because there's a child. She's not coming up positive for marijuana. It should be in the system. And so at that particular client, I probably will not take that negative as okay, she's negative. But like, we need to talk. And what really happened? What's going on?
Right. Yeah, and I think that we need to talk is a great opener because it's about concern, right? Yeah. So we got a couple of scenarios. Taking buprenorphine and the sedation is due to something else. She could be super sleepy. I don't know. We also do have some people who are sedated when their dose of buprenorphine is too high. That's another one that we'd edited in that's not in here. So possibly could be taking buprenorphine and the sedation is due to something else like fentanyl or alcohol. Patient could have tampered with that urine, and this is the point that came up here at the table already, that it would be unusual for someone who's using cannabis daily not to have cannabis in their urine, even if they'd stopped for a week. So those are some scenarios. Polysubstance abuse is hard to untangle. These are scenarios that will come up against frequently. That it's important for our office-based folks to think and know about substance use disorders other than the opiates alone, particularly looking at alcohol, benzos, and meth these days. But we know that when people are using more than one drug, it's difficult for them to achieve some sustained remission. And it's not entirely clear whether people are more or less likely to engage in treatment, or whether it's fair to say that the Suboxone is or isn't working in this case. So again, using your brain to sort of think through what's supporting someone in attaining their goals and what's getting in the way. And we heard some really great comments from our group here today about how do you sort through some of that stuff. You know from some of the previous sessions that alcohol and benzos are the riskiest, particularly when someone is taking their buprenorphine, because it takes away that ceiling effect, and it can you can then have respiratory depression and overdose, even if the only opioid that they're taking is the buprenorphine. So really asking about that. Look and see whether when somebody is using something like the marijuana, is it meeting criteria for a substance use disorder, and having that conversation with them too, especially these days. The marijuana, there's a lot of conversation about it's good for my anxiety, I'm using it for my pain, it helps me not, we have a lot of conversation about medical uses of marijuana. So we may, with our own biases, either over-detect substance use disorders or under-detect substance use disorders for marijuana use, depending on where you stand on that. So it's still important to go through the ASAM criteria. Is this affecting, is there a loss of control? And is there a loss of function as a result of the marijuana use, or any other use in this case? And back to our standards, you're going to maximize your social supports. And particularly for the marijuana, have your program think and talk about what are you going to do about marijuana. Our cups detect it. There are some places that special order cups that don't, because they don't want to have that conversation. That's a choice. We probably under-discuss and under-respond to marijuana. I'm looking at my Jasmine nurse to say, we probably don't have enough of that conversation.
No, I don't think so.
And that might be a learning curve for us.
The last urine I provided was during an assessment, and this individual had a card, they were able to go to the dispensary and get marijuana. And they were upset that it didn't show, so they waited because it took a little bit for the marijuana to show. They were like, wait, are they not giving me marijuana?
New twist.
They were upset that it wasn't showing positive.
Someone who wanted a positive.
Yeah,
they were
like it should be. Well, and that's an interesting one of, I think some of our patients are actually interested in what comes up in their urine because they're curious about what they're being given.
Yeah.
I can add something with marijuana. It's more serious than what we think, specifically because we're not talking about, like, when a client is in front of us, something happened before that. If this particular client is at risk to lose the custody of her child and she's still using marijuana, we really have to.
That might be a control issue.
That might be a completely different issue. I remember us having a case, the person was assessed, she disclosed smoking marijuana. She was not given a diagnosis for it at the moment the assessor felt she did not meet criteria. A couple of weeks later, she was high, baby drowned. So that just came back as a boomerang effect. What happened if she disclosed marijuana? What did you do? She told. So once there is a child involved in the picture, we have to look at the case completely.
It does change things. Yeah, yeah. And it's interesting. That's not a session that's in this curriculum, but it's something we may want to build into some echoes in the future about special populations and families with kids. Right. Yeah. So for this case, Cindy's questions. We need to talk. I'm concerned, right? How do you build some rapport and how do you start having that conversation? For us in primary care in particular, thinking about underlying psychiatric comorbidities, how do we want to treat their anxiety, PTSD, all that other stuff, right? We need to sort of pick through if they think they're treating themselves with the marijuana, can we offer them a more effective treatment? And if we're concerned about tampering, my favorite trick is here's some water, go again. And setting out there some of my own approach and expectations that I am not here to punish people for a positive. I'm here to understand what's happening for you, and if there's something that you feel like you need to hide from me, I'm not going to stop your treatment. I'm not going to get you in trouble. The thing that's going to get you in trouble is you continuing to use. So I want to, we need to talk, right? We have had some really interesting experiences when we ask people to go to the bathroom again. It's actually been a real relationship builder to have them come back with the urine that has 3 different things in it, unlike the one that they handed you the first time, and say, okay, now we can talk, right? Now I see what's going on. And when they experience that we're not going to shame them, not going to punish them, not going to abandon them, because those are the 3 things people are most worried about, then they may be willing to be more open in the future as well. Anything to add? Okay, third one, patient stable on buprenorphine, has been coming for monthly visits. You have no concern. And then they're negative for all substances, including buprenorphine. What are your thoughts? What are some scenarios?
I guess you could consider it diversion.
Could be selling it. Yep. And it's often, I find, the people that I think are the most stable and the most friendly and wonderful, and I look forward to seeing them as, oh, darn. Because if it's your business plan, you know how to manage the doctors. The ones who are giving me trouble, I'm not worried about diversion. Right? Yeah. They're not going to risk their business. Okay, so diversion is definitely a possibility. What's another possibility? I can't remember that guy's name that we were talking about.
Oh, yeah.
Yeah. Anyone want to take a chance on another scenario?
I have a question. This is Cindy for the medical team. Is there a low dosage that might not show up in their body?
Yes.
Okay.
Depending on the threshold for your cup, right? Okay. There are people who are on very low doses, so he may be on a really low dose, right?
Okay, so it's a possibility.
Kind of titrated or something.
I might expect that if I sent it for metabolites that I'd see a little something in there.
Okay.
To be something, but according to the notes for this particular case, and the person who wrote this one is in Massachusetts, that people who are on a low dose and relatively quick metabolizers may actually show up negative.
What will be that number? Like, what will be a low dose?
2 milligrams a day, 1 milligram a day.
Okay.
Mm-hmm. Other thoughts? So it might be we prescribe. Okay, yeah.
Just tampering, you got to consider tampering as well.
Yep, that's right. So how would the tampering work for this one? Oh, this one's easy. There's just nothing in it. Okay. You know, it's interesting though. I saw an interesting poster presentation at ASAM maybe 2 years ago, where they were doing oral DNA swabs and collecting urine specimens and doing DNA on the urine. So looking to see if the DNA of the urine and the oral swab matched. And 1/3 of the ones that didn't match still came up with something positive. So I like to tell patients, just because you're buying urine from someone doesn't mean they didn't use something too. So buyer beware, right?
Or a pregnant.
Pregnant men? Yeah.
Yeah.
Mm-hmm.
Oh, yeah.
Yep.
We get a lot of calls when I was in Allentown outpatient that we would send ours to Wasatsi at that point in time.
Mm-hmm.
And we would get a lot of calls. We're like, your guy's pregnant.
Yeah, gosh. So in a strength-based approach, I like to admire people's ingenuity, but also give them some of our own experience of what we've seen that doesn't go well when trying to use your genius, right? So some scenarios: diverting, ran out because maybe they needed more than you were giving them, and they ran out. So that's a thought. And that might be a really interesting question then of, you know, what happened this month that you needed more? And that would be a high risk for relapse. And at this point, whether they're negative, they probably are having some withdrawal and they might be really pretty miserable. Fast metabolizer or dilute urine, either because they drank a lot before they peed or they added something, or tampering to hide a relapse. So we got most of those, right? Go team. So detecting diversion, this is sort of, we're coming to the end of this presentation. Your participation has been awesome. Detecting diversion is a tough subject because you can never prove it, really. All you have is eventually somebody might tell you. You really have no way of knowing for sure that someone is or isn't diverting. And I think diversion comes in a lot of different flavors. I think when I was new in this business, I thought diversion really was the guy with the business plan. And we had a few, but much more often it's a much more subtle thing than that, that it's more about sometimes sharing to help other people, particularly common in couples who are one person's in treatment and one person isn't, or one person needs a higher dose, or mix and match, right? So couples can be tricky that way. People have very tight-knit social groups, and it can be really agonizing, especially these days with so many overdoses and so much grieving and loss. People can get kind of desperate about their friends who aren't doing well. There's also a fair amount of mix and matching for people who are relapsing and don't use this day, but then use their buprenorphine later. So using it more as a respite than a treatment for recovery. So lots of different ideas about what diversion might be. And you can't really know exactly what somebody's doing. But you can get a sense that they're not getting their full dose that you prescribe and that that's a problem, right?
I can,
yeah.
This is Cindy. There's another component, which is criminality.
Yeah.
And substance abuse is not just a physiological disease, it's also behavioral. Just the high some people get from the whole getting the medication, going out there, find who's gonna, it's sometimes harder than the physiological dependency.
Right.
So just looking at their criminal, we can do that. I do in the biopsychosocial, and we look at the criminal and legal history. We have someone with the past of sale, distribution, intention, that's someone that pay a little attention. If I get a positive or a call, okay, I do go and check the legal records
Yeah.
to see what's there.
And I agree with you, and I'm impressed with how often our impressions aren't correct, right? Like, so it doesn't mean that that's going to happen to that person or that that's what they're doing. We still don't know. Our index of suspicion might change based on those things, and that's important. It's all clinical data.
We have some that are solely based on need. They're willing to feel some withdrawal and willing to sell a portion of their prescription because they need the money to,
Yep.
Get out. And they recently lost their job. They're going to lose their home. They need to buy food for their house. So yes, it could definitely be a lot of
Complicated stories, right? They're complicated stories, and I think the clinically the difficult thing is being able to listen to the story and be responsive without getting sucked in, and without being reactive to the story. So helping people by, this is when you have really strong motivational interviewing skills, which I'm working on. You guys are better. But I think the more you can sort of help people say things out loud until they hear themselves identify their own problems and their own solutions, that's far better than us imposing our judgment on them, because sometimes we're really wrong. Yeah. So we need to include buprenorphine if you're prescribing, you need to be checking for buprenorphine, and we need to at least periodically check for metabolites. The metabolites will only be there if the drug that you're detecting has passed through the body into the urine. Melissa was mentioning people will crumble, particularly tablets are easy to dissolve in the cup. You'll see lots of buprenorphine and very little to no norbuprenorphine. They should be at least even, and probably more norbuprenorphine than buprenorphine in the confirmatory testing. So even people who are doing well, we should periodically send that for metabolites just to make sure that they're taking their buprenorphine. Random visits for pill counts for stable patients as well as the unstable patients. We found that we don't really have a great capacity to call people in to do random counts. A lot of our folks don't have phones. Our phone system for people to call back is, they'll never get through. So we haven't really been able to do that. Yeah, people don't answer their phones, and it was causing a lot of trouble. So we haven't really been doing that. Because we can't. Yeah, and we need our
really
others
need to be considered, because the criminality goes, and I'm not stigmatizing them. I just know the population and how, if I know I have an appointment with Jasmine next Thursday at 4, that gives me enough time.
4 days. Yeah.
Yes.
Absolutely. Absolutely. So we're not really able to do this. We will need partners to help us out, but we haven't really been able to do that.
Could it be done during the case manager meetings, like the BHIs or the CHWs, when they meet? Hey, let me see, bring
Pill counts, yeah.
Yeah, like
They can do that. They can't check a urine though. Yeah.
No,
right.
no,
Yeah.
but do the pill count.
Mhm.
So they cannot be called in and tell them, like, all right, come into the office. Well,
right.
Just do it at random.
Mhm.
They meet at least twice a month, right?
Yeah. Yeah. So each system is going to have to figure out what's within your capacity to do and do well. You don't want to implement something that you can't do well.
Mm-hmm.
And for us, that was calling people in for random stuff. What we have found is that people that we think are diverting in some way, we have them come in for very frequent visits, and that weeds people out because it's just too much of a hassle. So sometimes we're a little bit of a hassle. Check your PDMP. We know that it's you have to every time you write your prescription. Check your PDMP. And again, the PDMP. I'm speaking to the converted. Kevin knows this, but not just looking to see who the prescribers are and that there aren't other prescribers, but you want to check and make sure that they picked up the amount that you prescribed, that the timing is appropriate, all of those things, that they're not running out and that they're not telling you that they have less left over than you would count out based on the PDMP. So we look at sort of those 3 dimensions for the PDMP. Any unexpected prescription, any unexpected timing, and any of the sort of wrong doses. So what do you do to address the diversion? Knowing that lots of people out there use non-prescribed buprenorphine to do detox at home. That's a home remedy that's popular out there these days. Probably most of the diversion that that we hear about, and of course we're going to hear about it because it's the less criminal version, but most of what we hear is just people sharing their buprenorphine. And from a public health point of view, I'd rather have them sharing that than Percocet, right? So there's a lot of it out there. It's possible that the risk of diversion may actually increase as people stabilize. So some of the folks that we've had out there for a long time, I like to think about starting to discuss tapering doses at about 6 to 12 months. Never in a hurry, and there's a whole nother, we can talk about tapering doses another time. I put that out there and start preparing people for what that looks and feels like. Because over the long term, we don't really want people to be on 24 milligrams or even 16 milligrams forever. Some people need that, but a lot of people don't. And when they have doses that are high, then it is more tempting to share or sell. I think it's important to have clear and open discussions about the importance of not diverting, that it may not actually be very safe, particularly when other people may be using benzos and alcohol that you don't know about. I think a lot of our folks have experienced a lot of loss and grief, as we mentioned before. You don't want to feel responsible for a loss and grief. So talking to people about that. And if we really do have evidence that the buprenorphine prescribed is not going into the body it's prescribed to, then we have to stop. So we have, like I mentioned, we've stopped for some people. I don't believe personally in stopping in order to force someone to make a choice to a higher level of care. I think that sets people up for a pretty dangerous situation, but we do need to stop prescribing if people aren't coming to their appointments and are not using in ways that appear safe, and then offer them something else in exchange. So the next steps there, run the quantitative testing, look at the biometrics, the creatinine and the specific gravity, call them in for a pill count, or maybe go out there for a pill count, or see if one of your partners can do a pill count, and let them know your urine didn't show any buprenorphine. How are you taking it? We have had some people that just take it badly, especially these days when the drug companies switch which formulation they're using every other minute. Someone's going from films to tablets, they may swallow most of it before they absorb it. And if they really don't come to some of these more structured things that you put in place, or that random callback, if your office is able to do it, that's another check in the favor of this is a diversion consistent story. Okay, any other thoughts about the presentation?
Is that very useful, excellent presentation, Abby. Thank you so much. Unfortunately, I have to go. Thank you.
Great, thank you. All righty. We have a case, though. Do you know where it is?
Oh, yeah.
Okay.
Yeah, sorry, I forgot the computer. Yeah, it's on the
Computer issue. We'll switch spots.
Veronica, this is Star. I'd like to ask if you could put your email address in the chat, please,
Yeah, of course.
so that I can get you registered. Thank you.
Yeah.
And you said you're an intern, right, Veronica? You're
Intern at the One City Center in Allentown for Lehigh Valley.
oh, you're a summer intern. Awesome.
Yeah, I'm a college student.
Thank you. Where are you in school?
Marist College. It's in Poughkeepsie, New York. It's right on the Hudson River.
Lovely.
Cool.
Yes. Yeah. Welcome.
Thank you.
Thank
so
you.
much for having me. It's very interesting. I just don't know a lot yet because I am an intern, so.
Well, great. You're going to be an expert by the end of the summer. What's your project?
Right now I'm just doing like scanning and like downloading files, but they had me like sign up for a lot of meetings and to talk to a lot of psychiatrists, and I can like shadow them.
Oh, great.
Yeah.
Uh-huh. Great. So getting a little intensive in psychiatry along the way. That's great.
Yeah, I hope so.
At any point, if you want to come out and see what we're doing at NHCLV, let me know, okay?
Okay, thank you so much.
All right, Kate.
All righty. So,
Short version, because we only have a half hour.
yep. So I have a 48-year-old Caucasian male, helped with non-medication treatment. He's not aware of the presentation, and he did not help develop the question. So for strengths, I have that he's self-sufficient and he's independent. Question, what type of behavioral health techniques can we use and offer to get him to an appropriate level of care? So for social history and social support, he moved to Pennsylvania from California in October 2017 due to being with the need to be with his godfather, who was within like his end of life. So he was very sick, and he came out to be with him. He used both methadone and heroin, depending on which was easier to obtain, prior to attending a methadone program in Pennsylvania. In 2017, he tried to initiate treatment in July of 2018. He was incarcerated shortly after until he reappeared in March of 2019. And he reports a history of traumatic brain injury after being struck by a vehicle in New York during the 9/11 attacks. He was crossing the street and he got hit by a car. For education, he's a high school graduate, and he does report attending art school in New York, but he never really finished. He says that he stole his art. He stole his art before, something he likes to do. For legal involvement, he doesn't really discuss any legal issues or what exactly he was incarcerated for, but he does admit to multiple attempts at homicide, and he's currently on probation through Northampton County. For ACEs, he was physically and verbally abused by his stepfather between the ages of 10 and 15, and he reports being abandoned by his mother at a young age. He also does report that at one, he has been told that he witnessed his mother being raped, so he was there while it happened. For employment, he's unemployed and has disability due to the TBI. So extensive use history. We have alcohol, marijuana, hallucinogens, heroin. His first use was 11 up to 7 grams daily, and his last use was 327, but he has current use right now. He's been on methadone in the past. He was up to 215 milligrams. In California, he was up to 200, and then when he came here, he reports being between 110 and 140. Amphetamines, crack cocaine in the 1980s. So he has an extensive use history. For comorbidities, opioid use disorder, anxiety, ADHD, he has been diagnosed with explosive temperament disorder, hepatitis C, and the history of pancreatitis. He is managed by gastroenterology, so he follows them, and hypertension, which he doesn't really take meds for anymore, besides the thiazide, but he wasn't taking it after prison, so he restarted those. He is on buprenorphine naloxone, also clonidine in there too. Tylenol, Seroquel, Xanax, which I believe used to be prescribed from psych and no longer. And then of course any meds that he has a couple of meds that are managed by GI. So past behavioral health and community supports. So level care 3.7 inpatient at a facility in New York. He does report to completing 28 days there. He was in methadone maintenance program through New Directions for 11 months in 2018 until he went to prison. He was also on methadone in California, again 200 milligrams, and he had small decreases in dose prior to moving. He reports buying 90 to 110 milligrams of methadone prior to incarceration, but he isn't clear as to why he was discharged from the program. He has mental health at Holcomb and also an ICN, but he's not very engaged with those. We try to get him to be more engaged, and then he refuses any type of inpatient detox or extended stays. What motivates him for change? He does say that he's tired of using every day. He's getting too old for this. And he states he wants to control his pain since he was run over by a vehicle while crossing the street. Since then, he had multiple surgeries, a lot of trials of physical therapy. So he just states that he has a lot of pain. He's done a lot of pain management with different providers, and he states that nobody wants to take him, but he does continue to say that he just needs narcotics. He doesn't want methadone, Suboxone, anything like that. He just wants pain management. So again, proposed diagnosis, opioid disorder, anxiety, ADHD, same ones from before, the history of pancreatitis and the hypertension. For identified goals, we made referrals to pain management, and we continue to help him make those transitions to a provider. And we're currently encouraging him to return to methadone for treatment. He's resistant towards this option. He states transportation is an issue, and he can't go every day. He also states that drug addicts hang out there, so it's not good if I'm recovering. And team is helping him to obtain Lanta services, but he doesn't show up for the necessary interviews to get there. So in the office, he says a lot, kind of lists things that are barriers to him, but when we try to present options for those barriers, he does not agree with them. He doesn't follow through.
I forget how old he was, and I didn't write anything down. 48, okay. So we have a 48-year-old with lots of childhood trauma and who experienced a traumatic brain injury and physical injuries in the 9/11 when he got hit by a car, who has been struggling with polysubstance abuse. That was our theme a while ago, right? Polysubstance abuse for many years. May have been doing well in the past on methadone treatment, but his care was interrupted and then subsequently incarcerated. And since that time, the team has been struggling to get him an appropriate care plan, but he's continued to use well on the doses of buprenorphine.
Good.
And so the question really is, Kevin's question, too bad he's not here. This is a great case for Kevin in a lot of ways, because it's an overlap of the pain and addiction pieces, and addresses that question of when what we have is not the best tool to fit the situation, then what do we do? How do we handle ambivalence?
And something I wanted to add, I forgot to put in the presentation. So he was in the methadone program in Pennsylvania for 11 months.
Right.
And he didn't get any take-home doses or anything like that. So he was there for about a year and he never got that option presented to him. So something to think about too.
This is Cindy. Just to clarify something, he does not want to engage in drug and alcohol or mental health treatment. Is that what's going on?
Yeah, he won't. He won't engage with anything.
He won't engage. Okay, but he thinks he's in recovery, although he's using every day.
Correct. He's currently, well, what we think is using every day. He does come into the office. He looks extremely sedated. And then his urines and confirm show that he is using heroin. He does state that he does snort it. It usually sits like a day or two before.
And he using cannabis daily. That's what he says there as well.
Yeah.
So there is no SUD diagnosis. It should be. Well, no, I'm ready. I'm ready to go.
Yeah.
Okay,
So the way we like
I'm ready to go with him.
And Veronica, even though you said you feel like you don't much, you're welcome to ask questions. And I've heard Amy starting to ask a question, I think. Clarifying questions. Anything else you want to know about this case? What stirs up for you that you're curious about this guy, or what's happened to him so far that we know about since he's been in the Lehigh Valley? So we'll do clarifying questions, and we'll start with the folks who are out there on the call, and then we'll come back in here. And then we'll do suggestions. Okay? Cool. So any clarifying questions?
So my question was, and I mean, as you're talking, I definitely think there's that ambivalence, but how much of his resistance also do you think is his anxiety? Like, is that bigger than it's presenting?
He doesn't complain much of anxiety. He also doesn't want to engage with any treatment that has to do with it. He continues to come in and state that the only thing that he needs from us or from anyone is narcotics to control his pain, because that's that's all he sees is the issue right now. He needs to deal with the pain that he's experiencing from the traumatic experiences that he's had before, physically traumatic experiences, because he won't really talk much about the mental part.
But I think that's such an interesting question
No,
about
definitely.
the anxiety. I think sometimes anxiety does show up as the inability to follow through on a plan. Like you just can't stay with it. Also a sort of a sign of his traumatic brain injury that prefrontal cortex doesn't work all that well. So the executive functioning takes a big hit in traumatic brain injury usually. So between that and the polysubstance use, that he can get up and brush his teeth is pretty good, right?
Mm-hmm.
But I think that's a great question, Amy, about like what contribution is the underlying anxiety and the underlying trauma playing for him?
I think mental health is definitely a strong underlying component here that needs to be addressed. That's another thing we're having issues with is addressing that.
Okay.
So.
Other questions out there? Naomi, you got questions? More clarifying questions from in here too, or chime in.
I think she's about to.
Okay, come on, Naomi, you've got one more chance.
Oh, no, she put herself back on mute.
I have his mobility, his personal, because I know transportation is an issue, but even after the accident, is he able to walk on his own? Okay, so he's not like, cane, or so physically he's able to get to his appointment.
Sometimes he brings a cane. Sometimes he doesn't.
And is hepatitis treatment in place?
Yeah, he gets that treated by GI. At least he reports doing so, and the reports show that we have been able to look online that he's been going.
Is that usual?
There yes, the GI folks or infectious disease can treat hepatitis. Yeah.
And he's on probation, parole? No legal?
Probation.
Northampton County.
Yeah.
Okay.
He was just released in pretty much like beginning of March, I want to say, because that's when he reappeared.
Do we know what he was incarcerated for?
He doesn't speak much to what specifically his law involvement is, only that he's been incarcerated and that he's attempted homicide before in the past. Not when, where, if it was California, New York, or anything like that. Here.
Well, probably here, in the last 3 years. He's been living here. For him to be in county probation, so it's probably some sort of threats or something.
Yeah.
Who does he trust?
He doesn't. Anyone that he comes and sees, I feel like he's open to the most as he's ever been. Like, I don't think there's one specific person that he's more open to than others. He just comes and states what he needs to say. He'll come in like extremely early because he does have a partner that is also involved in treatment, and they live together. So he'll come early if her appointment's early or anything like that, and just hang out in the waiting room. But again, he's sedated a lot of the time too, so it's hard to have a good conversation with him. So.
Did the godfather actually pass?
I believe he has.
Because he came out this area to take care of that.
Is the partner an advocate for treatment?
So she states that she does not have an issue. The only reason that she is using is because he brings heroin into the home. When we tried to give them separate housing, they both don't show up for interviews, and they both don't follow up with anything that's needed in order to get that housing, to have separate housing.
Any children involved?
No.
No kids.
She has children, but they're older.
So they're both actively using. But she's being prescribed. He's not yet.
They're both being prescribed, and it's an issue right now because one is getting buprenorphine while the other isn't. So his partner, because she hasn't been engaged with anything, we've decided, like we discussed, and she wasn't really using buprenorphine properly, so we discontinued her for the time being to try to get her to more services. But he is not, so it's becoming an issue.
Okay, so he is getting the script for you.
Mm-hmm.
She is not, so therefore if he brings heroin, she's using that.
Mm-hmm.
Okay.
Or they may even be sharing buprenorphine at this point. It can, and this is just recent. This just happened this past week. The issues have arisen. Before they were both receiving buprenorphine up until this past week.
All right, any other questions that came up for the group out there? Naomi, Amy, Veronica?
No, I'm good.
Okay. All right, so now we're going to think about suggestions. If we want to sort of sum it up one more time, the couple who have sounds like some pretty locked in patterns, and the team hasn't succeeded in helping them to engage more broadly or meet their needs in a way that's helping either the team or the patients feel cared for. That's a tough spot to be in, right? This is a not feel good case. Yeah. And sometimes I think it's useful to start there and say, oh, this one just doesn't feel good, right? Because then we need to bring our extra emotional intelligence to bear for this one, because it's going to be hard. Any suggestions out there? Amy, do you have any suggestions for us?
I'm struggling, so I can't imagine how you are all feeling, because I'm just thinking about similar cases that I've worked with. And has he ever had a neurology appointment? Like, does he go to a neurologist?
Neurology. Oh, neurology. I believe he did follow a neurologist in the past. I don't know the extent of that, because it was another state. I'm not sure if it was in Pennsylvania. If it was for one of the networks, we can see. But I don't think he's seeing one currently.
Because I'm just wondering, like, if it is something, that's hindering his impulse control and all of that, like, if a neurologist appointment would be helpful. I don't know.
I know the referral's in the chart. I've seen it. So we're probably in the process of getting him there.
Okay.
What is he actually asking for?
Narcotics.
Methadone, but not a methadone program.
But
just
not
some sort of
methadone.
opioids for his pain.
So he states that's all he needs, because so he says that buprenorphine isn't enough to control his pain. He's on a pretty significant dose. I believe I want to say, he had a short period above 24 milligrams, and then now we just brought it 24 milligrams due to insurance issues. And then when we offered methadone, he said that's not going to work for him because it's not a good environment. Also transportation. So the only thing that will work for him is because that he needs some form of narcotics.
And do you know specifically how he's taking the buprenorphine? How often does he take it?
We've discussed him taking, so he takes 2 12s, he splits them in half and takes every 4 to 6 hours, depending on how much time he's awake. But so we've tried to go over that with him and doing that, and he's done it for a couple of days, and he says even that's not going to work. It doesn't matter how much buprenorphine you give me, it's not going to work. So that's why he's
I wonder if he's been able to tell you what he thinks working means.
Yeah.
Like what is that?
He says that he states that he still experiences pain. It's always about pain. Like if you ask him, it's like, oh, if you have like any cravings to use or anything like that, he states that he doesn't have cravings. He's only using because of pain, not because he's craving it.
Right. I mean, which is why treatment is important for him to understand that he's gonna be in pain.
Yeah.
that it's to take the edge off, as opposed to there is no such thing as no pain, especially with all the trauma his body has been. There's going to be some level of
His body, mind, and soul, right?
Yeah,
and they all work together, but yeah, lots of physical trauma too.
And I was going to just, what is likely, because we can get into the more of the behavior recommendations, but medically there are issues that need to be taken care of first, I feel. So medically, like, what would be a likely next step for a PCP to do?
Yeah, it's interesting. We actually, I think he initially was put on the, we have one physiatrist who comes to our office once a week and prescribes, and this guy was on his panel, right? So he's a physical medicine and rehab doctor. And he would be one of the people that we would refer someone to sort of evaluate overall what's the physical contribution to the pain that he's in and what are some best ways to treat that. Locally, one of the issues, and here's another one for Amy in her advocacy hat, we don't have good access to comprehensive whole person pain management. Most of the pain management locally is about spinal injections and then going to surgery for back pain, and that might not be the answer for a lot of people. There's some evidence out there that some of the things like acupuncture, physical therapy, and osteopathic manipulation stuff, like all of that together, along with CBT for pain, can be really helpful for somebody. But there aren't very many places that do that. Kevin's office, actually out in Hamburg, has been doing some group visits for pain that includes some CBT, some cognitive behavioral therapy, and they had some pretty nice results, and across the country that's gotten good results too. So some of our next steps would be, figuring out what is he willing to say yes to, and that's overall the question. Aqua therapy could be really good for him, and that is covered by his insurance. Going and getting in a warm pool and just starting to move around and trust your body a little bit to work on that. The cognitive behavioral therapies would be really important to adjust your expectations of what pain treatment can do for you. And I don't know, other than, what have they done to sort of figure out what's the origin of the pain, but I'm pretty sure that his PCP, Dr. Stockhausen, has definitely been looking at that. Sounds like they make plans and have trouble getting them to follow through. Does that support anything?
Yeah, no, I mean, it gives you a little bit of an idea. Like, it still leaves all the other needs, but if he's willing to explore those things, like, did he actually come to that appointment with that?
He did. So that's who he was evaluated by. So that's the person who was prescribing for him. But I don't know. I haven't.
This is your once a week doctor that you were just talking about?
And aqua therapy has been on the list for him. We presented physical therapy to him. He's done physical therapy over and over and over again. After the surgeries, didn't want to do that, so we presented aqua therapy. He didn't want it.
Yeah. Got more?
Are we at the suggestion stage?
Yeah, we sort of have moved on to, I'll say that from my point of view, the physical health suggestion is that we need to work on building some trust, and that may not include buprenorphine.
Yeah. So this is Cindy. My question for the team will be, what will be the motivation for him to do anything if we continue giving him what he wants?
Well, he's not getting what he wants, actually. So he's
okay.
Yeah, the buprenorphine is not what he wants.
So what's the change? Because then I missed that part. What have been the change with his medication? What he's getting then? He's getting nothing.
So one of the things out there in the primary care world, is that for many of our patients who are on chronic opioids for pain, they develop an opioid use disorder.
Yes.
And he's a prime candidate for that. He's got polysubstance use history. He's got traumatic brain injury. He's got underlying mental health issues. He's like a perfect storm of probably can't use his pain medicine all that well. So he would not be somebody that we would want to start on chronic opioids, but we would offer buprenorphine as a pain management and opioid use disorder treatment together. And most of the evidence out there suggests that a dose that he's on is highly potent for pain, has a high analgesic effect for about 4 hours.
All right.
So we ask them, instead of taking one big dose early in the day, to break it up into smaller doses. Most of our patients want to take 2 doses a day anyway, but that still isn't going to handle chronic pain for people. They need to split it into at least 4 doses, maybe more, which might be a suggestion for him. And then most people's brains quiet right down. They have as good pain control as they're going to get with any other opioid anyway. It's safer, and it gives you space to start working on getting him to physical therapy, getting the transportation in place, all that other stuff. So it's a bit of a red flag, a worry, it's a concern that even with the split doses that he's saying that it doesn't work for his pain. I would probably have him get to 6 doses a day,
but we're treating his physical pain is being treated. So if we look at the substance use, this is a completely different scenario right here. So what I hear is that we have someone who probably is gang involved. I can tell you that based on location, we really have to see this godfather was his godfather. That's a very common term in the gang world, which means, yes, there's a lot of other scenarios within that scenario. So when you have a client who's legally mandated and was granted permission to be in society because you committed a crime and now we're going to let you out back in society, and these are the requirements and the requirements for you to be stable, that does not mean that you're back 20 years ago when you had the opportunity just to go with your methadone and that's it. Your life has changed, and we all have to work together or getting him in reality, but like, you are legally stipulated to do this, okay? So we are recommending a substance abuse assessment, okay? And mental health. We have to address both at the same time. The anxiety is still there. Either he's on opiates, marijuana, and there's fentanyl there as well. So you will have, in order for you to continue receiving services here, you must complete a substance abuse assessment.
So here's a question for you that we were talking about a little bit earlier. So I think one of the things that's tricky, especially in a primary care office, and especially for some of the offices that are new at it, but he's challenging us too. So we know an answer. We know something's going to be good for somebody.
Okay.
But he's so far not responding to our offers. What are your tricks that, what are the ways that you do things that help people say yes?
You give them reality therapy.
Reality therapy.
Because if I know I can get away with what I want and I don't get and I get what I want and no consequences, that's what I ask first. Right. What's the motivation? And that's motivational interviewing.
Exactly.
Like, listen, it's different if you just had the accident, which he was abusing the drugs before the accident. So, yes. So we're talking at someone who had a previous history. Now the accident is the first alibi for me to continue this behavior. Okay? So we have to habilitate him. He has abandonment issue, loss and grief, lost the father, grew up and where substance abuse, that's the normal way for me. I don't know anything different. And if there's gang affiliation, I don't want to say I have craving because that means I still have a problem and you might do something about that. So if you ask me about cravings, I'm going to say no. Evidently, he does have cravings. So using a strength base, he's not in the streets. That's good. He's still going. He's building a rapport. So he knows where to go to get what he wants. So what I will recommend for that client is to give him a little bit of reality therapy. We will treat you. You had experience doing this. You were in methadone for 20 years. Yes, he was in methadone. for years.
11 months here.
11 months in
Yeah.
California and here. So
Yeah.
what you're doing is doing the same in a different state. So same equation, same result. We want to help you to see how you can do this different. Sometimes age, it sounds that one motivation for him is that the age.
Mm-hmm.
He'll be like, let's see if you can do this in a different way. But in order for you to do this, you must comply with X, Y, and Z. Because we're not helping him by just letting the blind guide the one that sees. That's what we're doing. I want A, B, and C. And medically, yes, we're going to provide you, but we're not just treating the physical part.
Mm-hmm.
We're also looking at his case with a recovery or abstinence or harm reduction base. Sometimes they appreciate when you tell them that.
I think that's right.
They appreciate that you care enough to say, in order for you to do this, we need to help you to be stable. Nothing is going to work, and you're just going to stay here. And hopefully in the near future, when we have clients with social denial and pre-contemplation, he will be a great candidate for us to do an intervention together and meet with him and sit with him and do this with him.
Mm-hmm.
Like your way doesn't work. You can
Right.
do this and over, but how long it's
not working.
It's not gonna work. And they tend, believe it or not, to respond. They tend to respond.
So I think as providers, definitely keeping the CRS involved, but his probation officer is going to be your greatest ally right now. Him off the street, he's safer than where he's at right now. That's the reality. It's either accept the assessment, go and do this while we continue to treat your physical part so that they can start managing some of the behavioral pieces. But a big conversation needs to happen with OPA. A big conversation needs to happen with his PO. And then the CRS can start touching on some of that reality stuff while we get him into the doors of a DNA provider that can do the assessment. And hopefully just having him sit, like you said, you guys need to build some of that trust. He loves art. Give him, gift him a one of those sketch pads. Here, while you wait, draw something. So, just let him express himself in a different way, and then when you come in, start discussing that. Because I know that's one of the beauties that you guys do. You take your time and you see them as an individual. You don't just do a 5-minute, here, you're well, your heart rate is good, okay, bye. There's more of a discussion. So I think that's going to be important to be able to build trust. Is you love art? Let me see what, you're sitting here waiting, might as well. So do something like that and then have the conversation of, we're going to have to involve your PO if you're not willing to accept a referral for an assessment. This is very necessary. It comes, right now it's life or death. And it's both you and your partner. It's not just you. So again, mental health and legal involvement are going to be your biggest allies right now. And CRS to help massage some of that in, and just be mindful that there is violence and violent outbursts and history of homicide or possible homicide, whatever. So it's just allowing a peer to talk to him, and then for us that do work with both the criminality piece and with the substance abuse world, and understand a little bit more about these gang affiliations that could be present. Just 2 hours of your time. That's what we're asking you for.
And there's a code when it comes to gangs. It means that recovery, it's not supportive. So it's stigmatized in the gang world, and the substance use is actually supportive. So that can be explored further in a treatment facility.
Yeah, great. Those are some really wonderful suggestions. We're 2 minutes over. Sorry about that, crew. Our next one will be in 2 weeks, which is 25th. Yeah, the 25th. I think we're going to have some special presentations from some of our other faculty about special populations, which will be really exciting. Please, 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 we haven't gotten a lot of responses back on our surveys. The link to the SurveyMonkey is in the invitation. If you open up the document there, it's also we'll put it in the chat, also the SurveyMonkey, so you can just sort of click there, but we'd love to get some responses. And in the last 2 sessions, we're going to be asking more specifically for some feedback about how you'd like us to continue. All right? Have a beautiful, wonderful, sunny day.
Thank you.
Thank you.
See you next time.
Bye.
Thank you.
More participation gets small.
Stop recording, please.